Just to echo the sentiments that everybody has expressed this morning, it has been a real pleasure and a very positive experience, a very collegiate experience to be part of Food for Me. And this has certainly been the case in Work Package 2. So it is unusual that I'm going to be introducing my colleagues as adversaries in this next section. I'm also delighted to be able to introduce my colleagues in a more esteemed way than I would have 4 years ago. Barbara Stewart-Knox began her career with Food for Me at the University of Ulster. She is now Professor of Psychology at Bradford University. And Arnout Fischer, who will be pitched against her, is now an Associate Professor in Consumer Sciences at Wageningen University. So congratulations to them. It's the default position that we think of personalised nutrition potentially being delivered through a public health system. And this is the perspective that Barbara will be taking today. Arnout will be coming in as a riposte to this and delivering the kind of commercial perspective. Now, what I'd like to say to you is that the information that Barbara and Arnout are presenting is very much evidence-based. But that said, it is not their personal opinions, and they have taken these opinions to extremes with the view of firing up a debate afterwards. So the way the session is going to run is that Barbara, who is dressed very subliminally, I must say, in a positive framing effect here, is going to be starting off with a presentation of 10 minutes or so. Arnout, the same 10 minutes. They're going to have a rebuttal at one another, and then we will have a floor discussion on this section. So without further ado, thank you, Barbara.
Good morning, everybody. Can you hear me well enough? Okay, so you know me, I don't know you. And how many people here would be working in a health sphere? Only a few. How many people would be working in commerce and industry? Substantially more. So I'm going to present to you the motion for rolling out personalised nutrition as part of our existing health provision. John touched on this in his talk and mentioned about how we don't exclude people. This is the only way to do it. I'm going to ask you another question. How many people here pay for their health care? How many people don't pay for their health care? Can I now there's at least one person here who says he doesn't pay for his health care, and he does. In fact, he pays a lot, and he probably pays a lot more than most of you in this room, because in the United Kingdom, we have a social exchange system where those who are paid more pay higher national insurance and actually pay more for our health care. And in a private system, some of us, probably John, would be better off. So we all pay for our health care. If you're not paying it somewhere or another at the minute, you need to start and think about that. You might be in trouble. Given that we all pay for our health care, that gives us rights. As we are citizens, whether you're health professionals or industry, you're citizens. You're citizens with rights. You're also paying, and that gives you consumer rights. So you're citizens and you're consumers, and it is your right to have your health care rolled out through your existing healthcare system, should you want it. Various reasons for this. Healthcare systems are already using apps in personalised medicine. They're already moving in that direction. And these are just an example of some of the national organisations in the different countries that we studied, and the type of medium through which they deliver health. So it's just a natural, logical next step, isn't it? That personalised nutrition would latch onto personalised medicine and be delivered through the health service. It's a foregone conclusion. There's no other argument. If it's part of health, general health, it's going to be integrated, and it's also going to be culturally specific. We've 9 different cultures or countries that we looked at in our consumer research, and by rolling this out under the umbrella of existing health services, what we provide is going to be culturally sensitive. It's not a one-size-fits-all. It is, but it isn't. Because in some countries, people might want to see a doctor at certain times, other people may not. The sort of diets, of course, are different in the different countries. So we can't roll out the same menus. So the different health services will be custom built already, existing and custom ready to deliver quickly to everybody personalised nutrition. It's a one-stop shop. It's easy. I go to my clinic and I get my health checks. And certainly in my country, once you're over a certain age, you get pulled in for various screening. As part of that, you know, okay, let's talk about what you're eating. Let's take the blood spot. It's easy. See, I don't have much time with my work. It's great. I can have everything done in one place. And if they find out something in my blood that's not dietary related, there's people in other disciplines, medical disciplines, there at hand. So it's integrated. It's all there. It's convenient. It can be online, or it can be a clinic I can walk into. And the other thing, I know when I go to that clinic that I'm going to see a fully qualified person, a doctor or a dietitian, hopefully. And that's what our consumers in our study were saying, that they wanted a guarantee that whatever they're doing, these people are going to be well qualified. So that's another matter. That's something we could discuss. The dietitians are obviously ready to go on this. So it's all integrated. I mean, if they find out I have a high cholesterol, I can be referred to the doctor at the same time for other health management, in addition to diet. So it's coordinated, okay? I think this is crucial. This is the social context of eating, very, very important. And this is something, again, that the health service is best placed to look at. It's culturally sensitive as well, being based in each individual country. And we can advise people, how do they cope in the family environment? How do they cope when they're out with friends? You know, all of these situations. The health service is called the health service. It's no accident it's called the health service. It's not called the disease service. It's not called the illness service. It's called the health service. So it's not just there to treat us when we're ill. It's there to keep everybody healthy and hopefully save money in the process. But it is a health service. It's not, so it's not about preaching to people, take more exercise, eat more fruit, eat more broccoli. It's not about preaching that. It's about helping and working with people. The danger, of course, is if the industry got their hands on this technology. You know, you're online, you give them some information, so they've got that. That's worth money. You don't know where that information's going to go. You get some feedback on what you say and the samples you give, and then they get rid of you as quickly as possible. They've got your money, you've got your piece of paper, and out you go. That's business for you, fast and efficient. That's great. I don't want to waste time. I want to be fast and efficient, but that's what you're going to get. And what do you get if the food industry is involved? Well, do the industry, are they going to think about the social context of eating? And this is the scenario. You could be in your personalised nutrition website eating your personalised diet like this. This is social eating. This is the social context of eating as it is in the modern world. Is that what we want? Or is that what we want to encourage? Or do we want to encourage this? This is what scientists advocate, yes? This was 5 years ago, 4 years ago? We're all at sea here. We're not at sea anymore. We're in a boat and studying food. Okay. The situation with family and friends. This is another matter. The health service are probably going to ask us about our lifestyle. They have time to do that because they're not after our money. And take into account whether we're married, whether we've children, even whether we've a family pet. The policy implications. Well, we've got health policy. Health policy is continually being revised. And it's for the greater good. I'm the goodie. This is the goodie's argument. And so we have good health policies that are getting better. Contrast with this innovation. What's innovation about? Yeah? It's about making money. It's about making money. It's not about doing good. That we know. And it was brought up in John's talk, are we catering to the worried well? Well, I suggest that industry would be catering to the worried wealthy, which is a different matter altogether. Here we go. Is it caring, as would be the health service? Would be caring and we have a patient model? Or would it be a consumer model? Profit. We're all barcode. Our information's going everywhere, God knows where, to be sold off to other companies to sell us stuff, even more stuff, and get more money out of us forever. Indelible. So who will have access to these data? I mean, you know, could your credit rating depend on your dietary habits, how healthy your diet is, you know? Well, there's somebody, I'm not going to lend them money. He's eating 2 burgers every day. He's going to pop his clogs, and then I'm going to have to pay out on this policy. You know? So it's not just about insurers. It could be... And what about security? I mean, if we've publicly rolled out personalised nutrition, we have regulations in place. We have a legal system. The hospitals already have, by law, the Data Protection Act. So the scientists, and we have to hold data within those constraints. For industry, we'd have to start a whole new chain of regulation and keeping them in line. Now, that's hard work. Lynn showed this slide about trust. And just to show you, again, who do the public in Europe, 9,000 people responded, who did, they worried that their data is going to be hacked by insurers and hackers. That's what they're worried about. That's their issue. This came up again and again. And it came up in every country. This is the effectiveness of personalised nutrition, which was just a baseline. But in every other country, they're worried about data security. And this is a government matter. This is a regulatory matter. And, but our current health service is already regulated. Lynn mentioned trust, and trust in the different agencies to give information was also discussed. With dietitians here today. I mean, the people we spoke to kept telling us that that's what they wanted. They wanted qualified dietitians. This is what the public want. And the health service is better able to supply this because we train them. We train them. Do we train them well enough? Another matter. But we can train them better. And we can trust these people. We can trust the doctors, we can trust the scientists, and we can trust the dietitians. But who do we not trust? Well, we certainly don't trust personalised nutrition companies. We don't trust food manufacturers or retailers. These are the least trusted to roll out personalised nutrition. So the European public, I'm sorry, they don't want your innovations. And in our survey, they made this perfectly clear. Nearly a third, they want personalised nutrition, and they want it rolled out through their health system, their existing health system. Only a quarter would want it rolled out by private health agencies. 28% wanted a dietitian, and the supermarkets only 17%. So that, I think, tells us something. So what way are we going to go? Let's hear what Arnout has to say. Are we going to go the health route, the innovative route, or some other middle-of-the-road route? And these are just a summary of the different arguments here that we can come back to that slide. So there you are. Well, we're happy, we're convinced that's the way to go. No argument.
Well, I put up far less flashy slides, but the first thing I already have one. Thank you. But the first thing is, Barbara ended with a slide where she said that a grand total of 2/3 of the people wanted a commercial service to deliver the advice. Of course, she presented it as an evidence for her point of view, that 1/3 wanted the family doctor to be in charge. Well, actually, why would we want to go for personalized nutrition? Well, we don't want to go to the doctor if we're not ill. Why would we go to a GP if we have nothing to be cured from? And personalized nutrition is not about curing, but about feeling better. And yes, we need expertise in there. But none of our people tell us that it needs to be a health institution. They're perfectly happy for a dietitian working in a commercial company. In fact, we find that people appreciate it if they can choose themselves and choose themselves to pay. They actually believe these are better services because they have selected them themselves, and they believe they're more likely to stick with them because they have put in the effort to select them. It's about a lifestyle. It's not only about health, nutrition, dietitians. People want a complete, healthy lifestyle of well-being. They want fitness together with health advice. And health services don't deliver these well-being programs that a lot of fitness schools are already thinking of doing. Barbara also made a very, very strong point that the different countries can actually make different ways to fit the cultures. But it's not about the main cultures. The differences within each country are much, much larger than the differences between countries. There are people who really think that DNA profiling is a good thing. Other people just don't care, and that's across all countries. Some want some kind of a group support like in Weight Watchers, others don't. Again, subgroups within all the countries. Some are looking for some kind of a no cure, no pay type of system. Others just want to pay regularly. Some people are indeed willing to pay more, about a third, others aren't. And people with high income want to pay most. And these might be the early adopters, which allows us to get a robust system in place and gives us the money to actually get it going before we start spending a lot on things. It's about subcultures, it's not about country-wide cultures. And a national health service will always look at the country as a whole. People want to be in control. Lynn already told that. And by choosing your own service and living with that, that will help you to be in control. The doctor will take away a lot of control for you. We see that people are wary of government programs telling them what to do. People get wary if it's implemented in a more or less mandatory employment program. So people are very, very wary of the big governments and industry telling them what to do. And in fact, in one of the slides Barbara showed, the fear of data abuse by authorities was actually larger than that by some of the private partners, which she cleverly didn't circle. Some people want to keep control over their own data. Others don't. What happens with your data if you go to Facebook? Some people worry about that, some don't. So there may be different levels of data protection for different people. Some people are worried about giving away their DNA, others don't care. So there's a huge difference between different groups of people. So we should cater for these different demands in the market, and smaller companies who all have their own profile can do that. So an ideal personalized nutrition services would be voluntarily. It's beyond just maintaining health or becoming more healthy, but it's a whole lifestyle and well-being thing. It is convenient and it includes personal contact, but it also fits to individual motivations, individual preferences of individual people. It's not only the nutrition advice that should be personalized, but the service as well, to fit the motivations of the people. And small companies are much, much more likely to be able to do that than a large health institution in a country. Especially if they have a large range of different companies that all have their own niche, that all cater to their own specific group of consumers. And that way you can ensure that in a country a much broader range of consumers get the personalized nutrition they want, they like. Healthcare, even if it's different across countries, within a country tends to go for one-size-fits-all approaches. Allowing that in small companies gives people empowerment, feeling of being in power of themselves. Healthcare puts the power with the doctor. It makes the user of a healthcare service a patient. It makes them a weak person rather than a strong person getting stronger. SMEs can give that all over lifestyle advice. Healthcare can cure your illness. SMEs are also much more flexible. If something new comes up, you may have a new SME that comes up and grabs it and does it immediately. If it doesn't work, it will go out of business. So it's a much faster turnover of innovative ideas. It will much faster focus in on what's working, and what's not working will just drop out because these companies go out of business. Once something is inside the health system, it will be there for decades, if not longer, without, well, much more chance to change it. So if we try to change this, SMEs will be much more flexible, much faster in taking up the newest ideas. So do we want personalized nutrition in the classical healthcare institution looking a bit like this? Or do we want it in an active, vibrant environment where people can choose themselves and choose the things that fits with them, that they like and that they think is best? Well, I think the latter is the obvious choice.
Okay, just a couple of quick points before we throw it open to you. You're not getting away with that. You're talking about illness and you brought it up. Why would we have a system that excludes the ill? You know, oh boy. I mean, you're saying, yeah, we're healthy, we shouldn't go into hospital for these services because, you know, we're not ill. Well, there are a lot of people who are ill and have conditions, and yes, they, you know, they deserve to have personalised nutrition as well. The other point is, you were talking about well-being and the wellness model. Well, I think I would be a lot happier if I could be saving money and not paying out for these services. I think that would help my well-being better than anything, indeed. And about data, you mentioned it, shot himself in the foot again. He said about companies going out of business. Well, what happens to my data when that company goes out of business? Where does that go?
Okay. Well, starting with the last point, I agree there should be regulations. A lot of the things can already be captured among some of the regulations. I'm not a lawyer, but that's a point of concern, and that needs to be dealt with. Going back the other way, wellness and well-being, not wanting to pay. Well, actually, you've asked who's paying for healthcare, and people who thought they were not paying were paying the most. If you put this into the healthcare system, people will pay, even if they don't use it. If you put it in a commercial system, people can choose to pay or not to. So actually, your point would support putting it to the commercial sector rather than the health sector.
Yeah, but if I don't...
And the first point was...
Okay, I was going to say, if I don't use it, other people will. And, yeah, I shouldn't... just because I don't personally use it doesn't mean it shouldn't be rolled out by the health service to include everybody.
But that goes back to your first point and saying we want to cure people who are ill because of nutritional deficits. And of course we should. But that is something else. We are talking about people who are healthy, who want to become more healthy or want to stay healthy longer. That's something completely different from the curative approach that classical healthcare has. Someone is ill, we fix them up. Of course nutrition is part of that, and it should be. But if we want to go beyond a minimum level of not being ill, then we're talking about things that are not traditionally covered in classical healthcare and probably shouldn't.
Well, what about the report recently published by the European Commission that shows we could save up to 13% in healthcare costs by putting healthy people through personalised nutrition services centrally run? That would be saving our public purse, our money.
Well, that would be if we get it going, if people would adopt it, if people would believe it. There's the facts that John's been presenting. We all know we should eat more fruits and vegetables. It's been a decade-long public campaign. It's not working. Just complying to that, 5 pieces of fruits and vegetables a day would have the same saving effect. So I don't think this is the way forward.
Okay. Everybody. We're quite certain that you would have something to add to this argument, so
yes,
let's have it.
Yes, Joe at the back.
Thanks. I'm Joe Goosen from Biosense. I'm part of the Food for Me team, but I think after this presentation, I would like to be the very first to say something. Three things. First of all, excellent. Thanks for staging a discussion, which is a societal debate that has to be taken by the authorities, by the policymakers, by the scientists, by everyone involved in healthcare and in maintaining health of our co-citizens, because we're not only consumers, we're also citizens. Thank you for that. So yes, that debate is a key thing that needs to be done, and I thank you for staging some elements of those. It's even much more complex than what you do there, but thank you for that. Second thing is, we're talking about personalized nutrition, so I have no questions, only comments to make. So, personalized nutrition, we're talking about choice, individual choice, making the choice on how and what you're going to do. So why should we fit all of the potential tools that we have to make personalized nutrition possible? Why should we fit them within one system? Why not allow everyone to make the choice, whether he wants to be in a public healthcare approach or whether he wants to be in a private healthcare approach? I think if we respect the principle of personalization and individualization, we have also to respect that choice, right? So, thirdly, the debate that you're staging and the questions that you're raising, they are very valid in terms of how you're going to put personalized nutrition into a society. And again, there, we see these days that the ways how authorities and public-private partnership, how they start to operate in very different scenarios, I think this is where we will see, with personalized nutrition, novel developments that will come forward. So thanks very much. Very well done.
Well, thank you, Jo. Indeed, I of course didn't present it, but some of the analysis we're still running in Wageningen shows that there is indeed a sizable group who would probably prefer it in public health, and a sizable group would probably prefer it in the open market.
Two markets, yes. Two groups.
But that's stepping out of my role, so.
I would like to add two comments. First of all, to the topic of data collection and making it secure. I would really ask whether that will be possible in any system. We all have experienced in the last year who all has access to which data. So that means if we approach it from a different perspective, that we are aware of the risk, that we cannot secure it, then we can manage our data better than we did before. As you pointed out, there are a lot of data available on other places from myself, which could be used to make some judgment on health, on behavior, on nutrition. So I think I would like to change the discussion in the public about this topic, and I think that is crucial for health and for nutrition, because it's ongoing. At least I follow it since 2000, and everything was shut down with this argument. The benefits have never been seen. And the risk, which like NSH and everybody else, we will have that again and again. I do not believe in security in data, whether it's on a computer, on a phone, wherever. And the second point is, for me, in the healthcare system, for my opinion, we have trained the people to be unresponsible for themselves. And that is a big risk for societies in the moment. We are not financially able to fulfill all the real needs existing. And I think we need to do a step back to educate citizens again to take responsible for their own life. They need support, and they need data, and they need qualified data, no doubt about it. But I do not think it's a good way always to say the society pays for what I do.
Okay, taking your first issue on data, this is where healthcare provision is a winner, because because they hold all your health data right back from birth, right back to birth. They have all that information to make a really, truly holistic decision on your health. On your second issue, it's everybody's right to have personalised nutrition, isn't it? So in giving everyone their rights as a citizen, the health service can do that. They can say, it's your right. If you want this, you choose. And then the issue of control, well, yeah, they've got control.
I cannot choose a journey.
Not yet. Have you anything to say?
No, she supports my
Yeah.
points.
Okay, we have one question here and two over there. Then we'll finish the discussion here and then come to the to the wider discussion at the table. So thank you. Could you give your name, please?
Thank you. My name is Chris Moore from one of these charlatan private healthcare industry. We have a group of companies that operate private clinics and laboratories, and I think there's a very significant shift in what's going on in the global market. And I think first thing is education. Our populations are much better educated on healthcare, and the choice issues that was just alluded to are essential. Here's the question. Paying for services, do you get better compliance or weaker compliance?
People believe
It's
better compliance.
Okay, here's the story. We've just operated a offer through a group of ours to some journalists to come and learn about the individualized healthcare model that we're offering. There were 6 international journalists, presumably they can read. 5 of the 6 collected incorrectly. We sell thousands of tests a month. We have very few that collect incorrectly. The journalists didn't pay. They just sent them in. So I think the idea for paying for services, we see much better compliance. We really do. Second thing, innovation. I think you're absolutely right. SMEs innovate. It's not something that's definitive, but it's very difficult for the big organizations, such as the National Health Service, to suddenly change course based on new scientific data that's coming out. We can, and we dare do it. I think we've been going nearly 20 years, so we're obviously going in the right direction. There will be always policies and interventions that go wrong. But just look at the National Health Service. Helicobacter pylori took 100 years before anybody agreed that it wasn't that ulcers were in fact a bacterial infection and not due to stomach acid. So that was the National Health Service ignoring the facts. And the last thing is, in the National Health Services, there's too much protocol management. Already, when you walk into the clinician, he's already made a decision based on a protocol rather than an individual. And that has to change. And the only way that's going to change is re-educating the doctors and dietitians. And I sat down with the Dean of Medicine from Monterrey University, and in Mexico, that's exactly what they're trying to do now. They're shifting the educational model from the macro healthcare to the micro. And the micro is us individually. And it doesn't matter if 90% of patients do better on one treatment, but if you're one part of the 10% that doesn't, you really don't care. You want to be getting the treatments relevant for you. So SMEs can absolutely provide a valuable asset in the industry. And yes, we have to be careful. But in all the years we've been doing business, I don't recall anybody, any of our clients, asking us about their data. Not once. No one has said, what do you do with our data? So some of this information that is perhaps perceived rather than factual. When they make the decision to do private medicine, they're quite happy to send in their data. They're quite happy to send in their samples. They never do ask questions.
Thank you.
Well, this is very much in keeping with some of the material that Lynn presented. I'm actually arguing now for another stance, but I'll go ahead. Our qualitative participants said that if they paid for this, that was a commitment. They're more likely to see it through. And it gave them some, and this is the downside for companies, they felt that they had more consumer rights, therefore legal rights, because they'd paid, and they expected a higher quality service, but it gave them, gave them rights.
But they get it.
Thank you. I'll take the last question if it's okay, just in the interest of time.
You made a few points. I was going to pick up on your last point, but that's okay.
Is that okay, just for time? We've got one last question, I believe, over here. Thank you. The two, yeah.
Yes, Martin Schmalzert from the Confederation of Family Organizations. The first point I wanted to underline is kind of the irony of of discussing this question of whether we should go public or not with this. This is a publicly funded project, right? So that means this is funded by the people because we pay taxes, and then the private sector is going to take it, and so we pay another time, when we buy the tools, that this project helped, discover with all the studies. I mean, it's kind of ironic. I just wanted to point that out. On the data protection issue, I think it's an illusion to think that you cannot protect your data. Honestly, now you have mobile phones that are almost as powerful as computers. If you put the algorithms that you've developed in your study inside the app, and you already have smartphones now that have all kinds of detectors and sensors, you don't even have to process that data online. You can process it right there on the phone, because you'll have all the algorithms necessary to analyze the profile of that person on the phone. But that means that your algorithm has to actually be on the phone and not somewhere in the cloud. And the last point I wanted to make is that there are a lot of presumptions made on the SMA's part, especially regarding competition, whether it works or not. Honestly, there's so many people bitching about Facebook, but honestly, there's no alternative. There's nothing else, unless you go on a social network with 2 or 3 people there. This is a natural monopoly. So it's not just about something that's bad, ceases to exist, just naturally. The second thing is illusion about consumer choice. Consumer choice is manipulated every day by advertising, by plenty of other things. So to assume that consumers are smart, the homo economicus, as we say, making always the rational decision, is an illusion. And everybody knows that. Behavioral studies prove this as well. So I mean, to say that consumers are smart enough and they're going to make the better choice is just ideology more than actual fact and data.
Can I briefly comment on that? Yes. As a scientist, I completely agree with you that Homo economicus is a hopeless model for consumers. I took a very extreme positive position here, which is neither my scientific nor necessarily my personal opinion, but I did that to trigger the debate that is going on around these things. And I think Barbara took a much more positive view on the health services than she probably always has. No? No, okay. No, but we presented fairly extreme views for this presentation. A lot of the criticism is indeed justified. Another thing, the EU invests both in innovation and in public health. So the next Food for Me, should that be sponsored by the innovation people or by the public health people? It's still tax money, but governments invest in both. So that's an issue for debate, I would say.
Thank you. One final question, thank you.
Ahmed El-Suhaimi from Toronto. My question, I suppose, perhaps is best directed to Lynn. When these results were published in PLOS ONE, those of us who are lazy just read the abstract. Those of us who are even lazier like me just read the press release. And I remember the press release from Newcastle. The headline that was picked up by a number of media outlets was, "Personalized diet plans will not be widely accepted by the public until regulations are in place to protect information about our DNA." So I looked through the paper and I had a hard time finding where those results were that merited that kind of conclusion. And I just wondered, the closest question was, I think, question 13 in the supplementary file that just talked about how confident are you that current regulations are in place? And I suppose disagree and strongly disagree would suggest that people want these regulations. So did the majority of participants in fact say that they either disagreed or strongly disagreed that the current regulations are sufficient for them?
Okay, could I just give Lynn a chance and actually thank Arnout and Barbara for their contribution this morning. We'll come up to the podium now and have the question and answer session, and Lynn will be able to respond to you. Thank you.